classes, and the educator will help you with that. And in the recorded sessions, you will have faculty who would have recorded the content, and if you haven't understood anything in the live class, and if you want to learn more, understand things more, you can always go back to recorded classes for revision. And we also have very crisp and concise notes, which is based on the CBME curriculum, which has lots of diagrams, lots of important content for your board as well as for your entrance examinations, and the most important MCQs for your upcoming next examination. All of this is based on the CBME curriculum. And we have the best of all features is the personalized counseling session, where a student will be given a mentor, and they will be your friend, they'll be your buddy, they'll help you in academics, and they'll help you with anything and everything that you need. You'll be given a plan, they'll analyze your strengths and weaknesses. Depending on that, they'll make you a plan, they'll tell you how to study, and they will hold your hands and make you sail through the examinations. And it's one of our best features, and you should definitely go for it. And we have three different plans, and in the basic plan you get pre-recorded lessons and live classes and quick revision examination modules. And in the standard plan you have live doubt clarification sessions as well. In the premium sessions you will get everything. You will get one-to-one personalized guidance, live doubt clarification, pre-recorded classes, quick revision examination module, notes, and everything. You can use my coupon code Dr.Sushma 20 for additional discounts on your subscription. And this is a tentative schedule that we have. And in one or two classes, we'll be done with brainstem. And I really hope that towards the end of these 3 or 4 classes that I have taken of the brainstem, that is midbrain, pons, and medulla, you will be able to answer majority of the questions, not just in your board examinations, but also in your entrance examination point of view. I hope these classes are helpful to you. Yes. Now, today's session, we'll be studying about the anatomy of pons. Okay. Now, let's look at a clinical case scenario here. Guys, we have a 45-year-old male patient who presents to us with sudden onset of paralysis on the left side of the face and right side of the body. Understand what exactly is the question being asked. Patient presents to me with sudden onset is the key, correct? Sudden onset paralysis of the left half of the face and right half of the body. He also complains of loss of taste sensation in the anterior 2/3 of tongue. The lesion is likely located in which part of pons? Okay. Again, I'm repeating this. There is left side paralysis, left side face paralysis, right side body paralysis, and anterior 2/3 taste is gone. Where is the lesion located? From the question given, what I can see is I can suspect that there is some pyramidal tract involvement, right? Pyramidal tract is definitely involved because there is paralysis of right side of the body. audible? Am I visible?
Visible and audible.
Yeah, let me just share the screen. Can you please make me the host so that I can share the screen?
Host, now I'm co-host.
Sure. Yeah. All right. Sorry, guys. Sorry for the delay. There was some issue on the technical side. I hope now you can see me and now you can hear me clearly. Yes. Now, yeah. Today, as I said, I suspect that there is a facial nerve palsy and there is pyramidal tract involvement now where the lesion is. Yes, in the last class, what did we study? We studied that 3, 4 comes from midbrain, 5, 6, 7, 8 come from pons, 9, 10, 11, 12 they come from medulla. This much concept I know. From my previous classes knowledge, I know that seventh nerve is getting involved, so the lesion has to be in the pons. Now the question is, which part of the pons? All these things we'll study in today's class. Okay, let's begin pons. Guys, pons means bridge, correct? Pons is something which bridges and connects the cerebellum to medulla oblongata and the midbrain. Pons is a bridge that lies anterior to the cerebellum that connects the medulla oblongata to the midbrain. In the brainstem, what is the order? I have midbrain, pons, medulla. So, pons is something that connects the medulla oblongata to the midbrain, and it is about just 1 inch long. Okay, you know, when we talk about pons, we talk about so many things, but guys, it's about only this much long. Pons, if you measure it, it's a very small structure through which so many fibers, so many tracts, so many things pass through, and it mainly acts as a channel through which the midbrain communicates with the medulla oblongata. Now, very important thing about pons is it contains all these sensory as well as the motor nuclei. What are the sensory nuclei that are present here, and what are the motor nuclei that are present here, and what happens when there is an injury to any of these nuclei and the fibers coming out of it is the crux of today's class. Pons has trigeminal nucleus, abducent nucleus, facial nucleus, and vestibulocochlear nucleus. Trigeminal nucleus is a constant. Trigeminal nucleus is a very big nucleus, guys. Trigeminal is actually present all across the brainstem. It is present in pons, it is present in midbrain, it is present in medulla oblongata. Whereas 6, 7, and 8 nuclei, abducent, facial, and vestibulocochlear, is present only in pons. These nerves, abducent nerve, facial nerve, and the vestibulocochlear nerve, they actually come out of the pons from the pontomedullary junction. So, if you have a patient that comes to you with an injury to any of these nerves, whether it is abducent, facial, or vestibulocochlear, you know which structure to suspect. If there is a patient who comes to you with pyramidal tract involvement and any of these nerve involvement, 6, 7, 8, and the fifth nerve, you know where to look at. So, the opening statement of pons is it is just a bridge that connects the medulla oblongata and the midbrain, and we have all of these cranial nerve nuclei which emerge from pons. Okay, now how we're going to approach pons is we will study how the anterior and the posterior surface of the pons look like. Then we'll take a transverse section and see what different structures do we see. Okay, so this is how we're going to approach the topic of pons. Now, how are we going to see pons in the first place? As I explained in the previous class, I cannot see pons if my cerebellum is intact. So what I'm going to do, if I'm taking the cadaveric brain out, I'm holding the brain in my hands like this. I'm looking at the brain like this, okay? And I remove the cerebellum. Now I'm seeing how pons look like, okay? Like how we did in the last class also. The same concept. Take out the brain, hold it in your hand, and remove the cerebellum and see what exactly you are seeing. Now, what I'm seeing is the anterior surface. Now, the anterior surface is convex from side to side, and it shows many transverse pontine fibers which converge on each side to form the middle cerebellar peduncle. Okay, anterior surface has this many transverse pontine fibers that just converge on each side. If the fibers are running like this, the pontine fibers, on the sides, they converge and they form the middle cerebellar peduncle. And in the middle, there is a very shallow groove called as a basilar groove, which lodges the basilar artery. That's it. In the anterior surface, what am I supposed to know? I have these transverse fibers. These transverse fibers are called as the transverse pontine fibers, which converge in the sides, as you can see, to form the middle cerebellar peduncles. Guys, what is a peduncle? Peduncle means a stalk. Peduncles means it is basically like a stalk. You have a fruit and it has a stalk. What is it doing? It is attaching the fruit to the tree, right? Similarly, peduncles are also those structures which attach the host structure to the central nervous system. When I say cerebellar peduncle, what exactly I mean to say is I have these middle cerebellar, inferior cerebellar, superior cerebellar peduncles. These are the stalks which attach the cerebellum into the central nervous system. That's it. Through these peduncles, I have all the tracts. If somebody has to reach cerebellum from cerebral cortex, they'll have to pass through these peduncles. That's it. Correct? Now, these horizontal pontine fibers, they sort of, they converge in the sides to form middle cerebellar peduncle. This is how the ventral view of pons looks like. This is how the ventral view of pons look like. You can see here how the view looks like, ventral view. But what are the different nerves that emerge from the pons? Okay, what are the different nerves that emerge from the pons? As I've already said, fifth nerve. Fifth nerve comes from the middle of the ventrolateral aspect of the form as two roots. Okay, there is a medial root and there's a very large sensory root. Abducent facial and vestibulocochlear nerve comes in the groove between the pons and the medulla oblongata. They emerge from medial to lateral, correct? From medial to lateral, if you see, you have the abducent, you have facial, and you have vestibulocochlear. How are the 6th, 7th nerves are coming out of the pons? They are coming in the groove between the pons and the medulla oblongata, meaning they are coming out of the pontomedullary junction. We have midbrain, we have pons, and we have medulla oblongata. Between the pons and the medulla oblongata, we have 6th, 7th, and 8th nerves coming out. Correct? From medial to lateral, it is 6, 7, and 8. Guys, let me give you one more tip over here. Any nerve which is divisible by the number 3 always lies in the middle. Oculomotor, abducent, and then your hypoglossal, all of these nerves which are divisible by number 3, they are all medial. All the other nerves, whether it is trigeminal, facial, 10th cranial nerve, vagus, 11th cranial nerve, they're all lateral. So by that rule, by the tip, abducent has to be medial, facial has to be lateral, vestibulocochlear is further lateral. Okay, from the pontomedullary junction, I have 3 nerves coming out: abducent, facial, vestibulocochlear. Understood? Any doubt? Yes. Then look at the structure, guys. This is what I was talking about. This is the groove for the basilar artery. Correct? This is the groove for the basilar artery. And this is the motor root of the trigeminal nerve. Smaller one. And the bigger one is the sensory root of the trigeminal nerve. You can see clearly in the midline, this is the pontomedullary junction, right? You can see the medulla oblongata here, and this is the pontomedullary junction. You can clearly see there is an abducent nerve. There is this roots of the facial nerve which are coming, and this is the vestibulocochlear nerve. This is the medulla oblongata. Okay. What are the different things that you're supposed to remember when it comes to the anterior surface of the pons? Number 1, we have the transverse pontine fibers. In the side, they go and converge to form the middle cerebellar peduncle. They have a groove for the basilar artery, and 6th, 7th, 8th nerves come from the pontomedullary junction. 5th nerve comes from the body of the pons. Body of the pons. Take home message: 5, 6, 7, 8 comes from pons. Right. Now, which cranial nuclei are located in the pons? Look at the guys. Trigeminal, abducent, 5th and 6th. Did we see these nerves in the previous diagram? Yes, we did. Still, let's look at other options. facial and glossopharyngeal. We did see seventh cranial nerve, but we did not see ninth cranial nerve. Did we see ninth cranial nerve in the pons or in the pontomedullary junction? No, glossopharyngeal nerve is coming from the medulla oblongata, isn't it? So obviously, this option is wrong. Vestibulocochlear and hypoglossal. Look at this. Where is vestibulocochlear? This is vestibulocochlear. Where is hypoglossal nerve? Hypoglossal nerve is not, this is, here is the hypoglossal nerve. Where is hypoglossal nerve coming from? It is again coming from the medulla oblongata. So obviously this option is also wrong. Oculomotor and trochlear nerve, they belong to the midbrain. So the answer to this question is trigeminal and abducent nerve. Okay. Now, this concept is very, very, very important. 3, 4, oculomotor and trochlear, they come from the midbrain. 5, 6, 7, 8 come from the pons. 9, 10, 11, 12, they come from the medulla oblongata. And I hope it is clear with this diagram as well as with this question. Never forget this question, guys. The entire chapter of brainstem syndromes, which you will study in medicine, is based on this particular concept only. 3, 4 is in midbrain, 5, 6, 7, 8 is in pons, 9, 10, 11, 12 is in medulla oblongata. If you have understood this clearly in first year itself, brainstem syndrome is a cakewalk for you. Because Weber syndrome is a midbrain syndrome in which there is involvement of third cranial nerve and pyramidal tract. If you look at medial pontine syndromes, basically it involves the seventh cranial nerve and the sixth cranial nerve and the pyramidal tract. Whereas if you look at the medial medullary syndrome, you will have the ninth cranial nerve involvement and the pyramidal tract. Depending upon what clinical history is given to you, you can approach these questions and answer them like this. If you understand which nerve is coming from which part of the brainstem. Okay. Entire chapter of brainstem syndromes just depends on your understanding of how the cranial nerves are coming out, and if they are damaged, what are the different manifestations. That's it. This will help you immensely in your clinical practice as well. If tomorrow some patient comes to you with a down and out pupil and there is pyramidal tract involvement, what are you going to suspect? You're going to suspect a midbrain syndrome. If a patient comes to you with facial nerve palsy and pyramidal tract involvement and a convergent squint, you are going to suspect pontine syndrome, isn't it? It is this important that you understand which nerve comes out from which part of the brainstem. And in your NEET examination, so many questions in anatomy just come from this one particular diagram. Either they'll give you a cadaveric image, or they'll give you an image like this and they mark one of these nerves and they'll ask you which nerve is this. Just the marking by giving some clinical history, or they'll give you a clinical history and ask you to mark one of these nerves. That's it. I cannot emphasize this enough. Every single NEET or AIMS paper has a question on this particular concept. It's a very important thing for your entrance examination as well. Do concentrate on this particular aspect. Now let us go to the posterior surface where things get a little interesting. Okay. Now posterior surface is kind of hidden. The view is hidden because I have the cerebellum. Again, take the cadaveric brain out, remove the cerebellum. What you see is the posterior surface. If you turn it, you will see the anterior surface, isn't it? Now, it forms the upper half of the floor of the fourth ventricle as well, and it is triangular in shape. When we do the fourth ventricles, we'll see what different structures are there. Okay. Now, the posterior surface is limited laterally by the superior cerebellar peduncles, and it is divided into symmetrical halves by median sulcus. Lateral to the median sulcus, there is an elongated elevation called as the medial eminence, which is bounded laterally by a sulcus known as the sulcus limitans. Now, this diagram, look at this. In this diagram, look at this beautiful picture. I just hope my voice is clear, guys. Please give me a thumbs up or just, write it in the chat box if my voice is clear. Because I see some my voice is not clear and it's breaking. If my voice is clear, please do give me a thumbs up or just write it in the chat box, please. Is my voice clear? Yeah. Okay. Now, continuing further, look at this beautiful diagram, guys. So this is what I was talking about. This is the posterior surface. This is the posterior surface in which you can see that there is a midline sulcus which divides it into two separate halves. And then you have the medial eminence, which is bounded laterally by the sulcus limitans. By the sulcus limitans. Okay. Yeah. What is sulcus limitans in the first place, guys? I hope you've studied a little bit about embryology. At least I am just hoping you know that there is a developing neural tube, and through the neural tube you have different structures coming in. There is a basal plate, there's an alar plate, and from the basal plate all the motor nerve nuclei come. From the alar plate all the sensory nerve nuclei come. I hope we have some idea about this. Sulcus limitans is the one that separates the basal plate and the alar plate.
Ma'am,
And that's how, yes,
your screen
is my
sharing,
voice,
your screen
am I
sharing,
audible?
you're audible, ma'am, but your screen sharing has stopped.
Okay, why is it happening today? Is it seen?
Yes, ma'am.
Yeah. So I hope you know a little bit about the basal plate and the alar plate. You know that there is a developing neural tube. In the developing neural tube, you have the basal plate and the alar plate. The cranial nerve nuclei that develop from the basal plate is all the motor nuclei. I hope you have an idea about these cranial nerve columns, right? There is a general visceral efferent. There is a special visceral efferent, GSE, GBE. I hope we know a little bit about this, isn't it? Yes. Now, this sulcus limitans is the one, this area that I'm pointing out over here. This is the sulcus limitans. This sulcus limitans is the one that separates the basal and the alar plate. So everything that is sensory is in the center. Everything that is motor kind of goes into the periphery. What are the motor nerve nuclei? Right now, we just did abducent nerve. Abducent nerve supplies the lateral rectus. It's an example, one of the examples of motor nerve nuclei, isn't it? So, this sulcus limitans is that area, sulcus limitans is that area which separates the basal plate and the alar plate. And what else do we have over here is this median sulcus. Then we have the medial eminence. Then we have the sulcus limitans. This is a very important order that you have to remember while you are mentioning these diagrams. Now, look at this nerve, guys. Depending upon what we studied in the last class, right? I explained this so many times in the last class. Which is this cranial nerve? Which is the only cranial nerve that comes from the posterior aspect of the brainstem? I've repeated this so many times in the last class, and you will give me answer in the next class. Which is this cranial nerve that is coming from the posterior aspect of the brain stem? Okay, yes, you can clearly see that it is coming from the posterior area. Now, again, going back here, this is the medial eminence, median sulcus, and the sulcus limitans. Importance about the sulcus limitans is that sulcus limitans separates the basal plate and the alar plate. It separates the cranial nerve nuclei into medial and sensory in the developing neural tube, which we will study in our upcoming embryology classes. Okay. Again, now we are coming to that one important concept that you will have to hammer inside your head, because so many questions are asked in your entrance examination from this concept. Okay. In the posterior surface, the inferior end of the medial eminence is slightly expanded to form the facial colliculus. Look at this. This is the area which I am calling as the facial colliculus. Now, what is this facial colliculus, guys? Now, I told you that I have 5th, 6th, and 7th, 8th cranial nerves which come from pons. Okay. Now, look at this diagram. 6th nerve is coming down straight. 6th nerve is coming down straight without taking any bend. Whereas the facial nerve, as you can clearly see, this is the facial nucleus. As the nerve emerges from the facial nucleus, it is going around the abducent nucleus to form an internal genu, and this forms an eminence called as facial colliculus. Facial colliculus. Look at this diagram, guys. This is a very, very, very important concept. We know how do you approach this is, I've told you that pons has 5, 6, 7, 8 nucleus. 5th nucleus was in the body of the pons, correct? 6, 7, 8 comes from the pontomedullary junction. Out of this 6, 7, 8 nucleus, 6th nerve is coming out straight. There are no bends, there are no curves. Whereas the 7th nerve nucleus, as it comes out, as the nerve comes out of the 7th nerve, that is, as the facial nerve comes out of the facial nucleus, it goes around the abducent nucleus like this. As it goes around the abducent nucleus like this, it's going, suppose that this is the facial nucleus, this is the abducent nucleus. From the facial nucleus, the nerve is coming, it is going around the abducent nucleus like this. This going around forms an eminence called as the facial colliculus. If there is any injury to the facial colliculus, this results in damage to the 6th nerve nucleus, meaning 6th nerve palsy will be there. There will be element palsy of the 6th cranial nerve, which results in the paralysis of the lateral rectus muscle, causing the convergent squint. This question has come in pretty much in all your entrance examinations, whether it is AIMS, whether it is NEET PG. This concept is very, very important, guys. In the pons, we have the 6th and 7th cranial nerve nuclei. Okay. Yes, that is my facial nerve nucleus forming this eminence called as facial colliculus. So in the inferior end of the medial eminence is slightly expanded to form the facial colliculus of the abdomen. Okay, understood? It's a very, very, very important concept, guys. You cannot afford to get this wrong. Yes. Now, let's look at the internal structures of pons. Now, if I take a cross section, pons as such, I told you, is a very, very small structure. It's as small as this, about 2 to 2.5 centimeters, 1 to 1.5 inches. It's such a small structure. And if I'm taking a cut section like this, okay, then I can see what are the internal structures which are present in pons. Okay. Now, the anterior part of the pons is called as the basilar part, and the posterior part is called as tegmentum. Okay, pontine tegmentum is the posterior part, basilar part is the ventral part. And to study the internal structures, I'm taking a cross section at the lower level, at the level of facial colliculus, upper level at the level of trigeminal nuclei. Okay, yes. Then if I'm taking a transverse section through the lower part, and these are the different structures that I'm going to see. What are the different cranial nerve nuclei will be seen if I take a cross section at the level of the facial colliculus? Now, I have the spinal nucleus of the trigeminal nerve. I said trigeminal nerve majorly has 3 different nuclei, which I'll teach you in some time. But spinal nucleus of trigeminal nerve, facial nucleus, abducent nucleus, medial vestibular nucleus, posterior and anterior cochlear nuclei are seen through the lower part. Of course, pontine nuclei is seen. And motor tracts are corticospinal, corticonuclear, transverse pontine, and MLF. MLF is a very important structure. Remember, guys, I'll tell you why MLF is important in our when I teach you the corneal reflex. Tract, spinal tract of trigeminal nerve, lateral spinal and medial lemnisci are seen. Okay, this is the diagram which you can see. It is taken at the level of the facial calculus, meaning facial calculus is seen at this level, right? Now you can clearly see that this nucleus of facial nerve, there is nucleus of abducent nerve, there is medial lemniscus, and you can see the facial colliculus here and the median longitudinal villus MLF structure which is present here, and the in the floor of fourth ventricle you can see all these structures. Then you have the superior peduncle, vestibular nuclei, inferior cerebellar peduncle. There is some reticular formation also. There is MCP which is formed under the transverse pontine fibers. This transverse pontine fibers, you can see that there is bundles of corticospinal and corticonuclear tracts. You can see the pontine nuclei here, and also you can see the trapezoid body. This is the trapezoid body and the groove for the basilar artery. Groove for the basilar artery. Now, what important structures that you have to remember in the sea of all these structures is you have to remember the motor nucleus of facial nerve, nucleus of abducent nerve, and this facial colliculus, which is important. You have to remember this. You have to write this diagram also. You have to remember the vestibular nucleus. You have to remember the spinal nucleus and the spinal tract and the nucleus of trigeminal nerve, which is important. You have to remember the MCP and the pyramidal and the corticonuclear tract and pontine nucleus. That's it. What different structures? I don't even have to memorize this. 6, 7, 8 nucleus you have to remember. Okay, superior cerebellar peduncle and middle cerebellar peduncle. You don't even have to remember because in the anterior surface you have the MCP. I've already taught you that. Other than that, two important things you have to remember is the pontine nuclei and the corticonuclear corticospinal and the corticonuclear tract. That's it. These are the important things you have to remember. Next, through the upper part, what difference do we see? We obviously see the sensory and motor nucleus of trigeminal nerve. We are let's say, guys, if I have to show you where exactly the I'm talking about the section, if I have to show you in this diagram, I can probably say at this level. If I take a section at this level, in the upper part of the pons, lower part I was taking at this level, upper part I'm taking at this level. So in the upper part, what are all the different structures that I will see? Okay, in the upper part, I'm going to see the motor and the sensory nucleus of the trigeminal nerve, pontine nuclei and trapezoid nuclei. Motor tracts, whatever that we had seen in the previous in this section, we are going to see the same section here also. Right now, what are the different sensory tracts that we'll see is the medial lemniscus. Medial lemniscus, okay, I hope you know what lemniscus are in the first place, right? Now the medial lemniscus carry the proprioceptive and fine touch vibrations. There is some network issue from my end. Let me check what it is. Just give me 1 second. Just hold on. I hope now the issue is sorted. I've just refreshed it. Is it more clear now? I hope now the issue is sorted. Please reply in the chat section. Is this clear now? I hope it is clear. Yeah. So coming back to the lemniscus, we have the medial lemniscus, lateral lemniscus, and the spinal lemniscus. All three lemniscus you have to understand and you have to remember. Okay. Medial lemniscus carries the proprioceptive and the fine touch sensations. Okay, fine. Now it's okay. Please concentrate on this. I'm very sorry for the technical lag. I don't know it is happening in today's class for the first time. I thought the class is very interesting today. It put in a lot of efforts in making the PPTs and everything. And I don't know, today only the lag and everything had to happen. Anyway, let's just concentrate here and try and understand. Okay, what exactly are we talking here? We are talking about the sensory tracts that can be seen. Okay, sensory tracts that can be seen at the upper part of the pons. If I take a section, transverse section in the upper part of the pons, what are the different sensory tracts I can see? Okay, first thing what I can see is the medial lemniscus. Medial lemniscus carries the proprioceptive and fine touch sensation from the opposite side of the body. That is, medial lemniscus carries the fibers from the dorsal column pathway. Dorsal column pathway fibers are carried by the medial lemniscus. Lateral lemniscus carries the auditory sensation from the opposite and partly from the same side as well. Auditory always has this connection because I cannot, both ears have to work in coherence for me to be able to hear things properly. So everything is interconnected in the auditory pathway. So lateral lemniscus carries the auditory sensations from the opposite and partly from the same side. Spinal lemniscus carries pain, temperature, and crude touch sensations from opposite side of the body. That is, spinal lemniscus is more lateral. It carries its sensation from the lateral antero-spinothalamic pathway. Lateral lemniscus is related to auditory sensation. Medial lemniscus carries sensations from the dorsal column. Three lemniscus, three questions, very, 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 very important. Medial lemniscus related to dorsal column, lateral lemniscus related to auditory pathway, spinal lemniscus related to antero-spinothalamic tract. All three lemniscus will be asked in your viva. Okay, they may just throw a question like this: medial lemniscus is related to what? All right, all three lemniscus related to what structures and where they are present is also very, very, very important, not for your board examination, but also for your entrance examinations. Okay, now this is the structures. These are the different structures that are seen on the upper level of pons. You can compare this diagram with the previous diagram I had shown, in which we had the 5, 6, 7 nuclei and also corticospinal tract, middle cerebral peduncle. You can see here in the transverse pontine fibers. You can also see the bundles of the corticospinal and corticonuclear tract, and you can also see the pontine nuclei. Then you can see the MLF, and you can see the cavity of the fourth ventricle here also. Okay, yes, and this is the motor root of the trigeminal nerve, which is smaller, main sensory root of trigeminal nerve, which is the bigger root. I hope you're getting an orientation about where am I taking the sections from. Okay, this particular section is from the upper part of the pons. The previous section I took was from the lower part of the pons, in which you were able to see 6, 7, 8 nuclei, and this is the fifth nuclei which can be seen at this particular level. Understood? Yes. Now let's look at the basilar part of the pons. Okay. Basilar part of the pons is the ventral part of the pons, and the tegmentum is the dorsal part of the pons. In the basilar part of the pons, what are the different contents I can see? I can see corticopontine, bundles of pyramidal tract, nuclei pontus, and transverse pontine fibers. Now, these corticopontine fibers are descending from the cerebral cortex to the pontine nuclei. What exactly are these corticopontine fibers? I'm going to explain each and every one of this to be able to make you understand. Now, these pontine nuclei are nothing but small kuti neurons that are sort of segregated, scattered in the basilar part of the pons. If you have pons like this, and these kuti neurons are scattered in the anterior aspect of the pons. These neurons receive their afferents, or I would say the first order neurons, from the corticopontine fibers of the same side. From these pontine nuclei, They cross over to the opposite side, forming the transverse pontine fibers. What they were doing? They were in the sides converging to form the middle cerebellar peduncle to go to the cerebellar cortex of the opposite side. Are you able to relate to it now? What did I teach you while studying the anterior aspect of the pons? What was there? We had this transverse pontine fibers which converged in the sides to form the middle cerebellar peduncle. Now, what is this corticopontine tract? From the cortex, I have the neurons coming in. They come and they relay onto the small neurons which are scattered in the basilar part of the pons, in the anterior aspect of the pons. From these scattered nuclei, from this scattered pontine nuclei, further certain fibers arise and they cross over to the opposite side, forming the transverse pontine fibers. They enter into the middle cerebellar peduncle, go into the cerebellar cortex. Essentially, what is pons? Pons is bridge. What is it bridging now? It is bridging the cerebrum to the cerebellum. From the cerebrum, I had certain neurons which came to the pontine nuclei. From the pontine nuclei, I had certain neurons arise and then they go into the cerebellar cortex. From cerebrum, it is bridging the cerebellum. This is what is pons all about. Understanding what pons, why do we have pons in our brain in the first place? It is acting as a bridge. It's connecting all of these structures. Are you able to relate what these transverse pontine fibers are? These pontine fibers are nothing but the ones which connect the pontine nuclei to the middle cerebellar peduncle. So they reach into the opposite side cerebellar cortex. This is called as cortico-pontocerebellar pathway. Cortex to pons, pons to cerebellum, cortico-pontocerebellar pathway. Understanding the concept behind how the cortico-pontocerebellar pathway is performed, why pons are called as bridges in the first place. Suppose if the cerebrum has to talk to cerebellum, it will send the signals through this pathway. What pathway? Cortico-pontocerebellar pathway. Every single pathway in the brain is formed like this, guys. You just have to understand how it is forming, why it is forming, through which structures it is passing. That's it. Okay. Now, corticopontine fibers are the first order neurons. Pontocerebellar are the second order neurons. Then we have the bundles of the pyramidal tract as well. The bundles of the pyramidal tract are descending from the crus cerebri to the crus cerebri of the midbrain. What is crus cerebri? Crus cerebri is the cerebral peduncle. What is the cerebral peduncle? It has the white matter, right? It has all of these descending tracts. What is a descending tract? My pyramidal tract. Pyramidal tract is broken into bundles by this transverse pontine fibers. Later, these are the bundles which cross over to the opposite side at the lower part of the medulla oblongata. Okay. Again, I'm just putting this picture to give you an entire overview of whatever we discussed so far. We have the sixth cranial nerve nuclei at the lower level of pons. This is how, if I take a cross section of pons at the lower level and see it under a microscope, these are all the different structures I will see. Look at this. This is the superior cerebellar peduncle, and these are the transverse pontine fibers. That is why you have all of these pontine nuclei here. You could have had the pontine nuclei over here also, but you're having it over here because from the pontine nuclei, you have these fibers going into the middle cerebellar peduncle. Every single thing that I have mentioned in this diagram has some role to play. Every single thing is important in this diagram, out of which the facial colliculus is the most important. You cannot afford to forget this concept of facial colliculus. Okay. Now, let's look at the facial nerve nucleus. Facial nerve is mixed nerve. It has both sensory as well as motor component. Most of the fibers of the facial nerve are special visceral efferent fibers. Now, guys, what is this SVE column? SVE column, what is the first column? We have the, I hope you are aware of the cranial nerve columns. I really hope you are aware of the cranial nerve column. And I'm assuming that you know something about how the cranial nerve columns develop in the first place, and what are the different nerves that belong to these columns. And we will definitely study this in detail, but for now I'm assuming that you know something about this cranial nerve columns, and I'm going ahead. Okay, the first column is the GSE column, general special efferent. The second column is the SVE column, special visceral efferent. Okay, so special visceral efferent is that column which supplies the muscles which are developed from the pharyngeal arches. I hope you know this. What are the different pharyngeal arches we have? We have the first pharyngeal arch supplied by the mandibular nerve, second pharyngeal arch which is supplied by the facial nerve. So, facial nerve belongs to this SVE column, and it has a very large facial motor nucleus located in the ventrolateral tegmentum of the caudal pons. Ventrolateral tegmental of the caudal pons. And now they innervate the muscles of the second branchial arch. Second branchial arch, which are the muscles? Muscles of the facial expression and the stapedius. Give me some examples of muscles of the facial expression, guys. For example, buccinator, orbicularis oculi, orbicularis oris, right? All of these are examples, no? So these muscles are supplied by the facial nerve. Now this facial motor nucleus is also involved in the corneal blink. What is this reflex called as? Corneal blink reflex, which is a reflex of very, very important clinical importance. Okay, facial nerve mainly supplies the muscles of facial expression and the stapedius muscle, but facial motor nucleus forms an efferent to the corneal blink reflex. How am I going to test it? Suppose if you take a cotton or any foreign object, and then if you stroke the conjunctiva, we invariably blink. This is what is called as corneal reflex. Now, what is the afferent and the efferent of this corneal reflex? Afferent is by the ophthalmic division of the trigeminal nerve, and the efferent is by the facial nerve. From the trigeminal from the ophthalmic branch of the trigeminal nerve goes into the trigeminal nucleus. From the trigeminal nucleus, this enters into the then the through the MLF, that is through the interneuron, through the MLF, this project into the motor neurons of the facial motor nucleus. From the facial motor nucleus, I have the efferent fibers coming in. Basically, from the fifth cranial nerve, that is ophthalmic division, from there the afferents come in. They go into the trigeminal nucleus in the trigeminal ganglion, and through the MLF. Look at this. Look at this. This is where the MLF is. Through the MLF, they go into the motor nucleus of the facial nerve, and from the facial nerve, we have the efferents coming in. Through this corneal blink reflex, I am able to test the patency of two nerves, trigeminal nerve as well as my facial nerve. Motor supply of facial nerve is tested by this. Correct? I blink. When I'm able to blink because of the orbicularis oculi muscle, isn't it? The blink reflex is mediated by the efferent of facial nerve and the afferent of trigeminal nerve. I hope this is clear in your physiology concepts. Okay? Yeah. Then abducent nerve and abducent nucleus. You know, guys, the muscles of eye. If you look at the muscles of eyeball, what are the different muscles we have? We have recti muscles and oblique muscles. Superior rectus, inferior rectus, lateral rectus, medial rectus, superior oblique, and inferior oblique. These are the 6 muscles we have through which we are able to move our eyeball. I am following my finger like this and moving my eyeball because of these muscles. Correct? I hope you know this. Out of all these muscles, only superior oblique and lateral muscles are lateral rectus muscle is supplied by different nerves, but all the other muscles, superior rectus, inferior rectus, medial rectus, inferior oblique, all these 4 muscles are supplied by the oculomotor nerve. Only the lateral rectus and the superior oblique is supplied by different nerves. Lateral rectus is supplied by abducent nerve. Superior oblique is supplied by 4th nerve, which is trochlear nerve. LR6 and SO4. SO4 is superior oblique supplied by the 4th cranial nerve. LR6 is lateral rectus supplied by sixth cranial nerve. Okay, I hope this you will study in ophthalmology, but at least this much you have to know. All the other muscles of eyeball are supplied by oculomotor nerve, whereas lateral rectus and superior oblique is supplied by abducent and trochlear nerve respectively. Okay. Now, abducent nerve supplies the lateral rectus muscle. Lateral rectus is important for this abduction. If I have to look to this side, if I have to look at this finger, I need lateral rectus muscle. If lateral rectus muscle is gone, let's say if there is abducent nerve palsy, this movement of the eyeball will be affected, and there will be movement of eyeball towards my nose, which is called as convergent squint. Don't go into the details of it. There is convergent squint and divergent squint. If the lateral rectus is involved, lateral rectus is gone, now the eyeball drifts towards the nose, isn't it? Because this pull is gone. Lateral rectus muscle is here. It is trying to keep the eyeball in position. If this pull is gone, obviously the movement will be like this, and this movement is called as convergent squint. Okay, this is called as convergent squint. Very important concept that you have to remember is facial nucleus is here, abducent nucleus is here. Facial nerves, as they exit, as they start coming out of the nucleus, they go around the abducent nucleus, forming the internal genu, which is called as the facial colliculus. Injury to facial colliculus causes injury to abducent nucleus, causing lateral rectus palsy. You have to write this and stick this in your bedroom. Keep seeing this. This is a very important concept. In the internal genu, I have the abducent nerve nucleus, whereas in the external genu of the facial nerve, what do we have? We have geniculate ganglion. I hope you know a little bit about that as well. Yes, this is what I was talking about. Right. Next, we have certain parasympathetic ganglion and nucleus also. Now, superior salivatory nucleus supplies the submandibular gland and the sublingual gland and the lacrimal gland. Inferior salivary nucleus through the lesser petrosal nerve supplies the parotid gland. This in itself is a entire difficult topic, parasympathetic ganglion and how they supply the different different glands in itself is a very big topic, and I really am short of time to explain this in today's class. Then in the cochlear nucleus, there are two cochlear nuclei, right? There is a dorsal cochlear nucleus and there is a ventral cochlear nucleus, right? Yes. Next, then what is cochlea? Something is related, cochlear nucleus is related to auditory pathway, isn't it? Auditory pathway is related to which lemniscus? Lateral lemniscus. Medial lemniscus is dorsal column, lateral is auditory pathway, and spinal is my lateral, anterolateral spinothalamic pathway. All three lemniscus important, you have to remember. Okay, yeah. Next, vestibular nucleus, there are four in number. Superior is in the lower part of the pons, inferior in the open medulla, medial to the inferior cerebellar peduncle, and medial in the lower part of the pons and the upper part of medulla. Okay, yes. Now, vestibular nucleus is something that is concerned with balance. They receive their afferent fibers from the vestibular nerve, whereas the efferent is via vestibulospinal, vestibulocerebellar, vestibuloocular, and vestibuloReticular fibers. Okay, just a quick question. In the midbrain, which was that one structure that was concerned with this ocular reflex? I explained this in very detail. You will tell me in the next class. Then we'll go to the trigeminal nuclei. Now, trigeminal nuclei is a very big nucleus, guys. It is a very big nucleus. It is present in all three structures. It is present in midbrain, pons, as well as in medulla. But we put trigeminal nucleus in the SVE column. I'll teach you this cranial nerve column in the next class. But majorly, trigeminal nucleus can be divided into three. Okay, majorly it has three sensory nuclei: mesencephalic nucleus, spinal nucleus, principal nucleus. All three nuclei carries different sensations. Okay, the concept is Let's say mesencephalic nucleus is concerned with proprioception. The concept is any nerve carrying the sensation of proprioception from any part of the body wall will come and relay in the mesencephalic nucleus. Any nerve which carries the fibers for proprioception will go to the mesencephalic nucleus. Whereas okay, let's just take a small question here, guys. There's a 50-year-old male complains of numbness and tingling on the right side of the face. Examination revealed there is a sensory loss in the V2, V3 dermatomes. The lesion is most likely affecting trigeminal nerve nucleus because it is the trigeminal is the one that has the sensory supply of the face. Okay, yeah. Now, the main sensory nucleus is the principal or the chief sensory nucleus carries the discriminative touch and pressure. So, any nucleus, any nerve that is carrying touch and pressure sensation will go to this nucleus. Which nucleus does it go to? It goes to the principal nucleus. Whereas any nerve fibers which are carrying proprioceptive sensations will go to the mesencephalic nucleus. From body wall, not just from face, from the body wall, entire body wall, wherever there is sensation of proprioception coming in, the afferent will go to this mesencephalic nucleus. So trigeminal nucleus is a very big nucleus. Don't think of when you know somebody says trigeminal nerve, don't think that number is 5, so it should be there only in pons. No, it is there in all across. The nuclei is spread across the brainstem in all three, pons, medulla, as well as in the midbrain. Okay, whereas the spinal nucleus is what carries the pain and temperature. So basically, trigeminal, 3 sensory divisions: mesencephalic nucleus, proprioception; spinal nucleus, pain and temperature; main chief sensory nucleus carries the touch and pressure. Okay, yes. Now, mesencephalic nucleus, as I said, they carry the proprioceptive fibers. All right. Now, don't worry too much about it. Just know this. Trigeminal is a very big nucleus, has 3 sensory nucleus which carry different sensations. All right. Yeah. Now, what is the blood supply of pons? Main blood supply to the pons is basilar artery through pontine arteries and anterior and inferior superior cerebellar arteries. But the main blood supply is by the basilar artery through the pontine arteries. Okay. Let me just take a very quick question here. Which artery supplies the anterior part of the pons? Now the options are ICA, anteroinferior cerebellar artery, superior cerebellar artery, posterior cerebral artery, and pontine arteries. Answer is quite simple, guys. As I told you, the main arterial supply is by the pontine arteries and rest of them are just feeding arteries. But the main artery is the pontine artery. Now let's look at the very, very important applied anatomy. Okay. Now, what nerve is present in the midline? If you look at the diagram of pons, what nerve is present? We have the abducent nerve. Okay. Let us say if there is a medial pontine lesion. What can result in medial pontine lesion? Cause is mainly vascular. Let's say I have a thrombus which has gone and it is sit in the one of the pontine arteries. What should happen if there is a medial pontine lesion? Okay. Number 1, there will be hemiplegia on the opposite side of the injury due to injury to the pyramidal tract. Let me take a very simple diagram here. Look at this diagram, guys. Suppose if there is an injury somewhere here. If there is an injury in the medial aspect of the pons, what are the different structures involved? You will have the corticospinal and corticonuclear tracts which are gone. Why are they gone? Because they are present in the midline, closer to the midline. You'll also have the 6th and 7th cranial nerves involvement, right? So when there is a midline medial pontine lesion, when there is a midline medial pontine lesion, we'll have hemiplegia on the opposite side. Why on opposite side? Because the decussation of the pyramidal tract takes place in the lower medulla. Until now, suppose if the pyramidal tract is coming from the cortex, it comes and comes and comes. reaches pons, reaches medulla, then it goes into the opposite side and then goes down. If there is a lesion somewhere here, because the tract has come over here, crossed over in the medulla, and then it has gone to the opposite side, lesion is here. What side it is supplying? It is supplying the opposite side. So hemiplegia of the opposite side will be seen if there is an injury to the pyramidal tract in the pons. Then I also have loss of proprioceptive sensation on the opposite side. Why? Because of the injury to the medial lemniscus. Medial lemniscus has to be present in the medial aspect. No, lateral is in the lateral. Medial is gone. Medial is gone, meaning proprioceptive sensation is lost. Why? Because it is related to the auditory pathway. Then there will be element paralysis of the muscles of mastication on the same side because of the injury to the trigeminal nerve. And also there will be element paralysis of the lateral rectus on the same side. Why? Because 6th and 7th nerves are involved. Then there will be element paralysis of the facial nerve as well. Look at this diagram. Again, I'm showing this. If the injury is somewhere here, 6th nerve is gone. So lateral rectus palsy is there. 7th nerve is gone. Element paralysis is present. Corticospinal tract is gone. Opposite side hemiplegia is present. Medial lemniscus is gone. This is the medial lemniscus. Medial lemniscus is gone. That causes injury to the medial lemniscus, incoordination, progressive deafness, so on and so forth. Okay. This is what is the medial pontine syndrome. If there is any lateral lesions, suppose if there is any lateral lesion, there will be lateral lemniscus which is gone. Lateral lemniscus is carried, what different sensation does it carry? Pain, temperature and crude touch, which is carried by the anterolateral spinothalamic tract. Spinothalamic tract is more lateral, whereas the dorsal column is more medial, isn't it? So when they're in the lateral pontine lesion, lateral anterospinothalamic tract will be gone. What does it carry? Pain, temperature and crude touch, isn't it? Then, of course, look at the diagram again. Look at the diagram again here. In this diagram, you can see in the lateral aspect, you have all of this inferior, superior, cerebellar peduncles. If cerebellum is getting affected, what do we see? Cerebellum getting affected, there will be ataxia, there will be incoordination, which all of these things we study in the upcoming classes when I teach you basal ganglia and cerebellum. So this is the lateral pontine lesion. You can clearly see a differentiation between the lateral pontine lesion and the medial pontine lesion. Medial pontine lesion involves the 6th and the 7th cranial nerves, facial nerve palsy, pyramidal tract and all of this, whereas the lateral pontine nerve, there will be loss of pain, temperature, cerebellar ataxia, nystagmus, vertigo. Suppose a patient comes to you with complaints of nystagmus, vertigo and pyramid and cerebellar ataxia and everything, you're obviously going to suspect a lateral pontine syndrome. Suppose a patient comes to you with 6th, 7th cranial nerve palsy and pyramidal tract involvement, you're going to supply a medial pontine syndrome. Even without knowing medicine, by just knowing the anatomy of pons, you will be able to localize the lesion, and that is the beauty of anatomy, and that is the reason why you have to study neuroanatomy with this approach in your mind. You may not know anything with respect to medicine at all. You may not know anything in brainstem syndromes. Just by knowing where the nerves are coming out and what structures are present at what level, you are able to answer which syndrome is it causing and the feeding artery. And that is the beauty of anatomy, guys. And it's so amazing. Just look at what lateral pontine lesion is and what medial pontine lesion is, how different they are. Suppose a patient comes to you with the following manifestations. In your first year itself, you can point out the level of lesion. The level of lesion, which is a neurology topic, it's a super specialization topic, but the basics start from your anatomy. If your concept is strong here, if you know that the spinothalamic tract is more lateral, when there is pain, temperature, loss, you have to suspect a lateral pathology. Dorsal column is more medial. When there is proprioception, vibration sense is lost, you have to suspect a medial pathology. Isn't it? Just by knowing this simple concept, when you sit in your OPD, when you're seeing patients, when you see certain manifestations, your mind immediately goes there. It's a lateral. maybe pontine, maybe medulla, maybe midbrain, but it's a lateral pathology. Something like dorsal column is more medial, medial lemniscus, it is medial. Sixth nerve is more medial. LR lateral rectus is gone, it's a medial pathology. Sixth nerve comes out from pons, it has to be a pontine pathology. What arteries supply? Pontine artery, basilar artery, pontobasilar system. Even without doing a CT, you are able to place where the lesion is, what nerve gets involved, what the feeding artery is. That is the beauty of learning neuroanatomy. Get your concept strong. You can ace your examinations in medicine and in your entrance examination. Please do read these topics again and again and again, because it is that important. If your basics are not strong, if your concepts are not strong, you will struggle in medicine. Okay, I have designed this entire classes in such a way that just towards the end of the class, you should be able to place the lesion. Okay, in your mind, you should be able to answer where exactly the lesion is present in the feeding artery. That is how I have designed all these classes. Okay, what is a lateral pontine lesion? Loss of pain and temperature. Medial pontine lesion, proprioception, vibration, and 6-7 nerve palsy. Got it? Now let's just take a very simple question and end in today's class. Damage to pontine nucleus is most likely result in impairment of motor coordination. Why? Remember, cerebral pontocerebellar system. Pontine nuclei, when you hear the word, you have to think about this particular tract. Understood? To summarize today's class, pons is just a bridge that connects the midbrain to medulla oblongata. Anterior surface, we have all these transverse pontine fibers. Posterior surface, all of the structures that I have described here. Fifth, sixth, seventh, eighth cranial nerves come out from pons. Medial syndromes, if there is a medial pontine syndromes, we have different manifestations. Lateral pontine syndromes, different manifestations. When the seventh nerve emerges from the seventh cranial nerve nuclei, it goes around the abducent nerve, forming the internal genu, which is called as facial colliculus. Injury to facial colliculus causes abducent nerve, abducent nucleus injury, abducent nerve injury, causing the lateral rectus palsy, causing convergent squint. In your examination, you will be asked to describe pons at two different levels, upper level and lower level. Rest everything I've covered is very important for your entrance examination and also for your knowledge. Okay, you should know which structure is present at which level. Okay, I hope today's class was useful to you. I hope you have found it interesting and found it useful. And we're going to have a very interesting class on medulla oblongata as well. And I really hope you go back home and you study the same concepts again and again and again. Keep studying. Towards the end of neuroanatomy, you will be able to diagnose brainstem syndromes. That is the goal of my classes, that you should be able to diagnose brainstem syndromes. You should be able to place that, yes, this is where the lesion is and these are the feeding arteries, and you should have a complete knowledge about the practical aspects of neuroanatomy, and that is how you should approach neuroanatomy in the first place. Okay, do not mug up, do not memorize, apply logic, find a pattern. You will find anatomy to be beautiful. All right, and if you have any doubt, you can definitely follow us across all these social media handles, and you can reach out to us and I'll be available for any, in case you have any doubts, you want any topics to be covered, you can always get back to us. All right, I really hope you found today's class useful, and I wish you all the very best. Keep studying, keep reading. Anatomy will be a cakewalk. All right, thank you so very much and good night, guys. And I'm really sorry for technical snags today, and I wish you all the very best. Thank you.